out of the Kingston office. So I supervise the death investigations in the Kingston, Ottawa, Cornwall triangle of the province. Another hat I wear is that I sit as chair of the Geriatric and Long-Term Care Review Committee of the Office of the Chief Coroner. And I'm here today with that hat on, so I'm going to talk to you a little bit about what we do in general, what the committee is, what the committee does, and then we'll look at the committee's latest annual report, and if we have time to go through some cases to demonstrate what we do and what sort of recommendations we make. If you've got any questions throughout, just interrupt. I don't mind at all, and I think we'll have lots of time, so feel free. So in Ontario, there are about 80,000 deaths a year, and the Office of the Chief Coroner looks at about a quarter of those. Of those, the majority are natural deaths. Second to that would be accident, then suicide, undetermined, and then usually a couple of hundred homicides a year in the province. Undetermined simply means either we just don't know, or there's a competition between two or more of the manners and we can't decide which one it is. For example, someone dies of drug toxicity and we don't know if it was intentional or accidental. That might be called undetermined. And about a third of our cases go to autopsy. The largest center for autopsy in the province is here in Toronto at our head office, but we also have regional units in London, Hamilton, Kingston, Ottawa, and now Sudbury, where we have forensic pathologists staffing. And then we also use community hospitals and community pathologists to do our non-suspicious cases in those local regions. So why does the coroner get involved? And I'll talk about those. This is the Section 10 criteria. And if a death occurs in one of those circumstances, then the coroner becomes involved. The coroner issues a warrant to take possession of the body. In this province, bodies are not property, so they do not belong to the estate, they don't belong to the family, they don't belong to anybody. But a coroner can take possession of a body for the purpose of investigation, and we do that. And then the coroner can examine the body and do whatever other studies on the body that he or she thinks is necessary in the public interest to accomplish three things. The public interest is important because we don't work on behalf of individuals, especially when it comes to circumstances such as civil litigation and so on. Our interest is really the public interest. And we do three broad things. First of all, we answer 5 questions. Who died? Where did they die? When did they die? What was the cause of death? So that's the medical cause of death. Did they have a heart attack? Did they have a stroke? Did they get hit by a car? And the means or the manner of death. So in Ontario, the choices are natural, accident, suicide, homicide, or undetermined, those cases where we're not sure. The second thing we do is determine whether or not an inquest is necessary. Some cases there are mandatory criteria for inquest. For example, if somebody strangles you while you're in police custody, your death will be inquested. So there are a small number of ones where it's mandatory, but otherwise the coroner makes the decision about whether to go to the inquest. And the third thing we do is we try to collect and analyze information so that we can make recommendations to prevent deaths in similar circumstances in the future. And in a large part, that's what the expert committees are about. So these are the broad criteria for reporting deaths to a coroner. This is the Section 10 criteria. And the thing that I'd like you to note is that it doesn't say that doctors, nurses, or police officers must report the deaths. It says every person. So that means that you, for example, if you are aware that a death occurred in one of these circumstances, then you, as it says farther down, shall, and when you see that in the law, that means you must, report the death either to a police officer or to a coroner. And if to a police officer, then the police officer in turn reports it to a coroner for investigation. So the types of deaths we look at are deaths that are the result of violence, misadventure, negligence, misconduct, or malpractice. Any unfair means, I'm still not sure what that is, but unfair means. Any death related to pregnancy is to be reported to the coroner. And on a national basis, we do collect information about deaths related to pregnancy and share that. Any death that is sudden and unexpected, this is certainly a common one in the elderly. Unexpected, again, most deaths are unexpected in that we didn't think that mom would die today. Having said that, perhaps a better term would be unanticipated. In other words, if somebody's 65 years old, 350 pounds, diabetic, smoking for 40 years, drinking 6 beers a day, and not taking any medications or seeing a doctor, it's not unanticipated that one day he might stand up in the kitchen, clutch his chest, and keel over dead. So it may be sudden and unexpected to the person who was having lunch with him, but to the coroner it wouldn't be sudden and unanticipated. So that might be a case where we would decide not to investigate. Any death that is from a disease or sickness which was not treated by a medical practitioner. Any cause other than disease, which encompasses accident, suicide, homicide, etc. And any such circumstances as may require investigation. So that just opens the door wide up and says, basically, the coroner may investigate any death that he or she thinks needs to be investigated. Generally, this allows us to do things like investigate deaths where you would come to us and say, I think they killed my mother in the hospital. So that person may not fall into any of the other categories, but you might have concerns about the care that they receive, or you might think that someone had done them harm, and so it allows us to look at those. And as I said, in those circumstances, the deaths are reported to the police or the coroner, and we investigate. In addition to those categories, there are a number of special circumstances that we also look at. For example, deaths in psychiatric facilities, deaths while in correctional facilities, and so on. And one of the categories is deaths in long-term care homes. So the Coroner's Act states that if somebody dies in a long-term care home that's registered under the Long-Term Care Homes Act, so these are licensed long-term care facilities. These are what most of us think of as nursing homes rather than retirement homes or boarding houses. So if someone dies in a nursing home or a registered, licensed long-term care facility, all deaths in those places must be reported to the coroner. And then the coroner will decide whether or not the death needs to be investigated and whether or not an inquest is needed. So how do we do that? In days gone by, the coroner used to go to every one of these. So if somebody was 95 years old, and had dementia, heart disease, diabetes, and proven cancer, and was palliative and died in a nursing home, the coroner still got up and went and investigated those deaths. It took us a while, but we finally clued in that really there's not a lot of benefit in somebody investigating those types of deaths. So what we do now is the Act still requires a notification of the coroner. So we use an instrument called an institutional patient death record. So whenever somebody dies in a licensed long-term care facility, the staff complete this record. It's now done electronically, and it's submitted centrally. And so in fact, when I come into work in the morning, if there's been deaths in nursing homes in my region, these will be in my inbox, so I can look at them. So they are fulfilling the law in that they are notifying the coroner. And then we have the opportunity to follow up on those if we think they need investigation. The death record requires the person who's completing it to answer a number of questions that should twig them to identify cases that do need to be reported. In other words, is it an accident? Is it a suicide? Is it a homicide? Well, obviously, if those are there and you get a yes tick, you better call the coroner. And further down, it also asks questions about, has the family expressed any concerns about care? Because again, those are ones that we do want to look at. Have there been an increased number of deaths in the institution? Have you seen an increased rate of death? Is there an outbreak in the institution? Have you been sending a lot of people to hospital in the recent weeks? If there's a yes to any of those, then the instrument instructs the person who's completing it to call the coroner and those cases are investigated. In addition to this notification, we have determined by policy that we will investigate every 10th death in each facility. So the facility keeps a patient death record, and every 10th one is automatically referred to the coroner, and we automatically investigate those regardless of what the circumstances are. It's a way of sampling so that we can keep an eye on the particular facilities and see what's been happening. So when the coroner attends those, there may not be much of interest in the circumstances of the death itself, but the coroner also has an opportunity then to review the institutional death record to see what happened in the last 9 deaths, where they occurred, what the cause of death was, and it may twig some concern to say, you know, look, either you don't know what caused the last 9 deaths, or how come the last 5 were head injuries and you didn't call us, or they were fractured hips or so on. So it gives us a chance to supervise all of the facilities. So under that arrangement, in the recent years, we look at 3,000 to 4,000 deaths in licensed long-term care facilities every year. Again, the vast majority of those are natural deaths, and most of them are without significant concern. They were, as we found out before, most of them are straightforward natural deaths and people who get old and get sick and die. But we do see a significant number of accidents, and certainly suicides, homicides, and undetermined deaths are not uncommon. And in long-term care facilities, we probably see, as you can see there, usually 4 or 5 or 6 homicides a year as well that we investigate along with our police partners. And we'll talk a little bit more about those when we get into some of the cases. One of the additional ways in which the Office of the Chief Coroner investigates deaths is to refer them to expert death review committees. So the investigating coroner will, with appropriate assistance, whether it's police or forensic pathology or whatever else is necessary, complete an investigation. If there's outstanding issues, then we have a number of options to go further. One is to go to inquest, so we can have a public hearing of the circumstances of the death. We can have a regional coroner review where someone like me would get all of the parties together in a room and close the door without lawyers and without family and hammer out the answers to the questions and come up with some recommendations. Or we can refer cases to expert committees. And the Office of the Chief Coroner has 6 expert committees. These are constituted usually by a chairperson who's someone in my position, a regional coroner. There may, in fact, I think on all committees there are coroners with appropriate skills in the area who also consult. And then we bring in experts from outside the coroner system to sit on these committees. So for example, in the pediatric committees, we have pediatricians, we have child welfare experts, we have police, we have crowns, and we have pathologists, and we have coroners. So we bring all of those people together and review the cases that are referred, make recommendations to the referring coroner about further investigation, make recommendations about the possibility of inquest, and then make recommendations in general about ways in which similar deaths could be avoided or in the future. So the committee that I'm going to talk about is the Geriatric and Long-Term Care Review Committee, and that's the one that I chair. So the purpose of this committee is to assist the Office of the Chief Coroner with investigation, review, and recommendations. Again, all of it aimed at, in the public interest and to public safety, to try to create recommendations that would avoid deaths in similar circumstances. And we look at deaths that involve a broad range. Most of our deaths involve individuals who die in or while they're resident in a long-term care facility, whether it's a retirement home or a licensed facility. But we also look at the care of the elderly in general. So they don't necessarily have to be in a facility for us to review the death. This committee's been at it since 1989, so it's been around for a while and produced a lot of good work. I've had the privilege of chairing since, has it been 2 years? 2 years. So I'm really new relative to the committee. And I think as of this year, there's nobody on the committee who was there at the start, is that right? I think our last one retired this year, but at the end of last year, we still had one person on the committee who'd been there since '89, so they do bring with them a lot of history and expertise. So this is what we set out to do with the committee. As we said, we want to assist the coroners and the chief coroner by making recommendations. The committee provides expert review of the care, so we have clinicians on the committee who can comment on the care given. So I am not a geriatrician, and I would be out of my depth in a lot of cases to say whether or not a particular treatment was appropriate or the best course for a particular patient. But we do have people on the committee who can make that comment and are recognized as experts. The committee produces an annual report. That's what we're going to talk about shortly, and that's a public document. So it is available to you and to anybody, but it is of particular interest to those who provide care to the elderly, and it's something that's looked at very carefully by those in the industry and done so every year. The committee helps to look for systemic issues. So because the committee receives reports from across the province over a period of time, they can identify trends and systemic issues in the industry and in the care of the elderly that perhaps individuals, even individual investigating coroners or regional coroners may not appreciate because we have the focus of our own investigations or our own regions. And similarly, to identify trends and risk factors and bring those to the attention of those who provide care. The committee is also there to some extent conduct and certainly to promote research in areas that where there isn't good evidence for a particular treatment or where we need more information on a go-forward basis. And also to stimulate educational activities by recognizing the systemic issues, by referring to other agencies for their input, sometimes in the development of protocols, or at least in general, some indication about where we should look to protocols, and where appropriate to disseminate information. So you'll notice in the reports that some of the reports come with references, so that individuals who are reading those and have an interest in the particular issues identified can actually go to the literature. The references are there that the committee uses to make the pronouncements that they do. So how do we do it? The cases are referred to the committee by the regional supervising coroner. So in the province there's 10 people like me who supervise particular regions. Either the investigating coroner will make a recommendation to the regional coroner that they want more information, or the regional coroner may identify it by his or her review of the case before the file is closed. So in that case, the cases are referred to the executive lead. It's Kathy Kerr, who's with me today, who leads not only our committee but several others as well. And together she and I will assign the cases to the person on the committee that we think is appropriate. Sometimes that's one person, sometimes it's more than one. For example, if there's issues of care and there's a heavy component of the use of drugs or pharmaceuticals, we might give the case to both a clinician and a pharmacist so that we can get expert input from both. So at least one member, and sometimes more than one of the committee, reviews all the information submitted. So they'll get the medical records, they may get the review by the compliance officer from the Ministry of Health, they may get police records, they'll get the coroner's records, the autopsy report, the toxicology, the whole package, and they will go through that in a very detailed way. Following that, we will meet as a committee, so all of the experts come together, and the person or persons who have had that case assigned will make a presentation to the committee. So they'll take us through their draft report of their review, and at that time, all members of the committee have an opportunity for input. So there may be significant changes made, there may be recommendations made that, hey, we need to look more at this particular thing and bring it back, or it may be that at that sitting we can all come to a consensus and approve the recommendations that are generated. And then that final report with the recommendations goes back to the regional coroner. to inform his or her investigation and let them know whether or not there should be more done. And the recommendations are then forwarded to the persons that they're aimed at. So if there's a recommendation for a particular long-term care facility, you know, you need to do better at this, or you might consider this, then the recommendations will go to that facility. If they're open, broad recommendations, as we'll often see to example, they'll be addressed to healthcare providers, then we have a list of organizations that we distribute the recommendations to at the time that they're made so that they can be distributed to their members. And then at the end of the year, we compile an annual report, and that annual report includes the recommendations that were made through the year, and that's available to anybody. So that's what we'll look at now. Any questions about how we get here? Okay, good. The last report we put out was in November, and as usual, it refers to the year before, so it's actually 2010 reviews, released in 2011, because it takes a while to compile the report, to have it translated and meet the requirements to post publicly on the government website, so it takes a little bit of time. This was the membership of the committee when these reviews were done. You may or may not recognize some of the people, but I just point out that we have representation by geriatricians, by family physicians who primarily practice care of the elderly. We have a pharmacist, we have a dietitian, we have a nursing representative from the Ministry of Health who's involved in the compliance office. So this is the branch of the Ministry of Health that inspects and supervises care given in licensed long-term care facilities. So they do regular routine inspections of long-term care facilities, but they're also involved when there's an issue. So if somebody dies in the facility and there's issues raised, they will also do an investigation, and we generally have access to that information as well. And then I sit as the chair, and Kathy there is the executive lead to make sure everything gets done and done on time and done well and edited and properly distributed. In 2010, we had a relatively quiet year, as you'll see by some of the other statistics. We looked at 11 cases and generated 22 recommendations. The general issue categories tend to be the same over the years. Some have said that's because we're not learning our lessons, and some have said, well, that's just the way the industry is, and I'll let you make up your mind as we go through some of them. But generally, what we looked at in 2010 were issues around medical and nursing management. So what did the doctors and nurses do? Use of drugs in the elderly, particularly the issue of polypharmacy. So a lot of the elderly have multiple drugs, and they are certainly a vulnerable population when it comes to drug interaction. So it's an increasingly important area. Issues of communication, usually between families of the elderly and the healthcare providers. The use of restraints in the elderly, and issues around documentation of care provided. And in 2 of the cases, we didn't make any recommendations at all. So when we look at the split, medical and nursing management, and you'll see that over the years, tends to be the biggest area that the committee looks at, and that's logical given that often we're making the referrals to get the input of the clinical experts about the care that was given to these individuals. So that's often the area that we're looking at. And then communication, drugs, restraints, and the industry. We'll call it the industry, but these are generally recommendations made to the policy makers and often to the Ministry of Health, who manages this area of care. And just another way to look at it, again, most of our cases involve recommendations around the management, the medical management of the care, but a significant number as well around communication and drugs. That's a very busy slide, but that's a look at the same material since 2004. And you'll see that the trends are pretty much the same. The big winner is the medical and nursing management. The second one, I think, is a toss-up between communication and recommendations to the Ministry of Health and policymakers. And then use of drugs, admission, discharge, transfer procedures, less of that lately because of policies that have been instituted. Capacity and consent, again, less of that lately because there are more policies in place. And use of restraints, which is probably, we'll probably see a bit of a blip. I know in 2011, we looked at least 3 deaths, I think, related to the use of restraints. So we'll see a little blip and a few more comments on that in the next annual report. And of course, the use of restraints is of great interest, such that it's actually now addressed in legislation. That licensed long-term care facilities must avoid the use of restraints, whether it's physical or chemical restraints. And that makes life difficult in many ways, and certainly presents an area of conflict sometimes between the providers and the family when it comes to an opinion about the best way to ensure safety with or without restraints. So are you interested in seeing the cases and what we did? Okay. If you get bored, just leave and I will know. I'm going to refer to some notes because I don't have all of these cases completely memorized, but feel free to ask me questions about the details if you think it'll help. So the first case was an 83-year-old woman who died of oxycodone toxicity and heart failure in a hospital after she was retired or transferred from her retirement home. Okay, sure. Everybody knows oxycodone, Percocet, OxyContin, Percocet, Percodan, oxycodone. Okay, and much in the news lately. So this particular woman had actually been admitted to the retirement home from home. She'd had a fall and she'd suffered some injuries and she had a wrist fracture and she was on oxycodone as a result. But for reasons that weren't completely clear, she remained on that throughout her stay and until she died 7 months later. In addition, she was on a number of other medications, including benzodiazepines. These are sedative drugs like lorazepam and Valium, that sort of drugs. So there were some concerns about her medications. And she tootled along okay for a few months, and then one day she developed distension of her abdomen and abdominal pain, and she was quite sick. She was treated with, and she had some diarrhea with that. So she was treated with loperamide, which is Lomatil. This is another narcotic medication that we give to slow the bowel down in cases of diarrhea. She also received Gravol or diphenhydramine. And because she didn't improve, she subsequently went to hospital where she was found to be in heart failure. And for the heart failure, received some more morphine, also given more Gravol and a drug called scopolamine. So, and then she went on to die. The concerns that the committee looked at were primarily around the use of drugs and especially around a thing called the anticholinergic effect of drugs. So certain drugs have an effect on the elderly to do things like impair their balance, impair their cognition, impair the movement of their bowels, etc. And unfortunately, a lot of the drugs that we use have this effect. And when you combine them, they have an additive effect. And that was certainly in play with this woman. In addition, in people who have heart failure, they don't metabolize the drugs well, so they tend to accumulate in the system even more. The other concern was that in somebody who's on an opiate, like oxycodone, who develops a big belly with pain and diarrhea, the most common reason is that they're constipated. And it was felt that that wasn't appreciated here. And in fact, they gave them a drug to slow the bowel down even more. And a drug that combined with the ones that she was on to make her sicker. People die of constipation. It is a recurrent theme with our committee. It is a recurrent theme with the Office of the Chief Coroner. So it's not a benign condition, and it's often the result of things that we give people, especially in the elderly. So it's an important thing to know. So the committee made a number of recommendations, all of them around the use of drugs, which may or may not mean anything to you. But again, things like loperamide, which is a drug to slow the bowel, generally don't have a place in the care of the elderly, and certainly not in the treatment of diarrhea for which you don't have a cause. And the most common cause of diarrhea in the elderly is that they're constipated and they get a thing called overflow diarrhea, where the loose stool up behind the hard stool runs around it and comes out the other end. And if you don't appreciate that, then you just make the constipation worse. Similarly, Gravol really has no place in the treatment of institutionalized elderly. It's not particularly effective for nausea, and it has this anticholinergic effect which can make them sicker. Similarly, opioids in the elderly, we certainly want to make sure that we're using them appropriately and then in the appropriate dose, and an argument could have been made in this case that 7 months of oxycodone for a fractured wrist was probably a little long. And then just to emphasize again that when you mix all these things together, they have a combined effect which can be detrimental to the patient. So that's the sort of recommendations that would come out around drug use, and those would be common themes that we would see repeated. So people who treat the elderly are keen to read that sort of thing, because it steers them, hopefully steers them away from that and makes them aware of those issues, so that when they're renewing medications or prescribing, they think about additive effects and they think about anticholinergic effect, and they think about whether or not they're making this person worse by giving them the drugs. Second case, 83-year-old man died in hospital from pneumonia and a fractured humerus, an arm bone, suffered in a fall a week before. And the issues in this case were primarily around delayed notification of the doctor and failure to recognize or prevent dehydration. So in this case, the gentleman had a fall in a nursing home, had some bruising and had a painful shoulder, and was watched by the staff, but was not investigated, and the physician was not notified of the case until I believe it was about a week later. By that time, he was quite sick, and he had signs of dehydration and kidney failure. And in fact, when he went to the hospital, he was found to have kidney failure and pneumonia and dehydration, and in spite of aggressive treatment, could not be saved, and so he died. And if again, it was felt 83, generally doing well with a broken arm, should be a survivable injury, but was complicated by these other factors. And so the recommendations in this case had to do with those two main issues. And the first one was directed at the industry in general, and that was that there should be a policy in every long-term care facility for the notification of the attending physician in cases where a person falls and has an injury. Most places have that, but believe it or not, not everybody does. Although in the majority of cases when it's left to someone's discretion, the right decisions are made, it was felt that it's better to have a policy that when there's identified injuries, the physician should be notified within a certain period of time. And in fact, when this physician was notified, prompt treatment was instituted, but it was a week too late. To medical and nursing management in general, just a reminder, and again, this would go out to the Ontario Nursing Association, the Ontario Long-Term Care Association, the Ontario Hospital Association, etc. So some of those bodies who oversee the care to be, again, aware of the issue of reduced oral intake, especially in people who've had injuries and the development of dehydration and kidney failure in the elderly, especially the ones on medications that predispose them that way already. Now, when I would suggest, if you're interested, that you look at the report, because what I'm giving you is a very brief summary. The recommendations come along with a discussion of the case in a broader sense. So the recommendations are based upon a more fulsome discussion of the issues, not just you should do this, you shouldn't do that. The reasoning for it is given in the discussion component. In the third case, an 84-year-old man with dementia and aggressive behavior died in a long-term care facility having had an unwitnessed fall that might have involved another resident. So there's a question about homicide in this case. This man had dementia, and he had psychiatric and behavioral issues as a result. And this is a growing issue in long-term care. As we have more and more people with dementia and more people living longer and more people with behavioral and psychological symptoms of dementia, the management of these people in groups becomes more and more difficult. This man was in fact admitted to a secure special care unit in a long-term care facility because of his aggression, which continued to escalate over the course of about a year and a half, such that he was threatening staff, threatening other residents with death, and pushing other people. He himself was demented and was at a high risk for falls, and in fact had had a number of falls. And on this occasion was found on the floor, having had a fall. He said that somebody else pushed him, and again, and the police certainly appreciate when all of your witnesses are demented. The issue of credibility is a live one. But he said he was pushed. Another resident, also demented and with behavioral issues, said, yeah, he sat on the couch and so didn't like him there, and they had a fight and pushed him off. And but they were never able to say for sure that that's what happened. But that's probably what happened. In any case, he was monitored there that day. He developed some hip pain. He was sent to hospital, and was found to have a fractured hip, but not one that needed surgery. So he was sent back to the nursing home on bed rest initially, and then following that, instructions to increase the mobility and to weight bear and so on. Unfortunately, over the course of the ensuing months, he was not able to mobilize and developed problems with pressure ulcers, infections, and went on to die. One of the issues identified in this case was that when he first went to hospital, they put a catheter in, which is a common thing that we do in people, having worked in Emerge, it's a common thing we do in people with fractured hips, because in our department, they can't get up and around. There's a good chance they're going to the operating room. We'll put a catheter in. Problem is, he went back to the nursing home with a catheter, and it stayed in for the next 6 months or so until he died. And that's not an uncommon practice because there are some who feel that a dry patient and a dry bed makes for better care. But in fact, the indications are that urinary catheters, except in cases where there's true urinary retention, reduce the mobility of people, and actually those folks tend to have more trouble with skin ulcers and immobility. And the committee felt that was an issue here. So they had an opportunity to make a recommendation to remind people that unless there's true urinary retention, you're better to deal with incontinence than you are to have an indwelling catheter. And especially over a long period of time, people do tend to develop urinary infections, and then they go on to get urosepsis with infection in the bloodstream, and it's a common way to kill elderly people. The next case, is this of any help to you, or interest, curiosity?
Yes.
Okay, all right.
Oh, yeah.
So this 89-year-old woman died as a result of a head injury after she was assaulted by her roommate. Again, this was a situation of a woman with dementia who was in a secure unit in a long-term care facility, and she was there because she herself had aggressive behavior. And she was known to be aggressive towards other residents and also towards the staff. And she had been in this facility for a couple of years at that time. She herself had a number of falls, none of which resulted in serious injuries. There were other residents in this unit who also had trouble with aggression. A particular one they had quite a bit of difficulty managing. And in fact, she spent time in a specialty unit outside of the long-term care facility. So some hospitals have psychogeriatric units, specialty units, that try to deal with the most difficult of these behavioral situations. And she was sent there for a number of months. And a plan was developed, and she seemed to be some better, and she came back to the long-term care facility. And she was watched closely for a few weeks, and then she was placed as a roommate to the decedent. And within a week, the decedent was dead. Now, of interest in this particular case was that the perpetrator was known to be aggressive, often with racial intolerance and racial intention. The perpetrator was white and the decedent was black, but they put them together. And they knew that the perpetrator had often been aggressive around issues of race and color. So on the day in question, the decedent was found on the floor, and the nurse noted that the perpetrator was standing over her, kicking her, swearing and making racial comments. And it was fairly clear to all involved that she had inflicted an injury on this woman. She was watched for a time. She developed signs of a head injury, and she was subsequently transferred to hospital where she died because of bleeding in and around the brain. So this is a concern. I think most people would say that's not something that we want to have happen to our mother or our father. But it certainly highlights the great difficulty that people providing long-term care have when there is nowhere else to go, and where you have multiple people in a facility with these problems, because it's pretty hard to keep them from interacting with each other. Certainly things could have been done differently in this case. For example, this was probably not a good pairing in a room. But having said that, it could equally have happened with the two of them passing in the hallway at some point. But the fact that it happened within a week of putting them together certainly makes you think it wasn't a wise move. A number of years ago, the Office of the Chief Coroner did hold an inquest into 2 deaths in a long-term care facility in similar circumstances. And the committee was involved in the review of those cases, and in fact, one of the persons on the committee gave expert testimony at that inquest. So we knew about that personally, and so a lot of the discussion around this case referenced back to the recommendations that the jury made at the time of that inquest in 2005. Because a lot of those recommendations that were made had not been acted upon, or at least the results were not evident at the time of this death. And so the committee had an opportunity to go back in the discussion session and say, look, this is what was said years ago. This is what's happening now. We've still got some work to do. And they were able to bring that in the form of recommendation back to the ministry and to those who make recommendations. Just to quote you from their discussion, because I think it is an important topic and one that's growing. The committee said that the current environment in long-term care homes continues to be significantly shaped by the presence of a large percentage of residents with cognitive impairment, and many residents have behavioral and psychological symptoms of dementia. BPSD is the term. The jury in 2005 stated that long-term care facilities have become the new mental health institutions in Ontario. And in fact, they have. And unfortunately, as is often the case, the resourcing and training is trying to catch up to the reality of the population mix. So in this particular case, a number of there's quite a lengthy discussion, and then a number of recommendations, including the need for private rooms for people who have aggressive behavior, and that's certainly been taken to heart. And in the construction of new facilities, we find that there's many more private rooms, and the move is towards that for reasons like this, and also for reasons of infection control and personal well-being. But of course, most of the people in the province don't live in new facilities. They live in facilities that were set up as either shared rooms, 2 or 4 in a room, or at least a shared bathroom between the reality that we have to live in, because we can't rebuild all of the facilities that we would need. They recommended a protocol for transfer to specialized units for people who are identified to be at high risk for their aggressive behavior. They recommended again to government that they need to fund and develop more of these specialized units. There are some in the province, but they're difficult to get into. The waiting list is long. I know I managed one in a regional center which was always full and always had people waiting. And while they wait, there's nowhere to go except to make do in the nursing home, which can be a very difficult situation. And then some recommendations around development of management plans, because the committee recognized, and so did the jury in the previous inquest, that often the care plans that are developed in specialized units don't translate well to the real world in the nursing home, because staffing ratios are different, staffing complement is different, access to medical experts is different, and the physical plant is different. So it's important that when people like this woman who was the perpetrator come back into the nursing home, that the plan is actually developed for the nursing home, not for the hospital, and that there's some connection between the people in the hospital and the nursing home to make sure that that works, both before they come and after they come. And then a recommendation around tracking people's behavior to make sure that the interventions that you've selected actually do something. So if we change somebody's drugs, we want to make sure we have an accurate record of what their behaviors were like in the days and weeks afterwards to know whether in fact they got better or worse. And there were some issues in this case around that being done in an effective manner. By the way, the only mandatory cases that our committee looks at are homicides in the long-term care facilities. So we do look at all of those in the province. The rest we do on a discretionary basis. The next case involved a 59-year-old woman with Down syndrome and dementia. And she was in a long-term care facility where she had moved from home because her mother wasn't able to manage her anymore. She, in fact, had become aggressive. But over her time in the long-term care facility, she became more and more dependent and less mobile as her condition progressed. And she developed some problems with skin breakdown. And so she needed special seating in a wheelchair. And there were issues that around bed movement. And in fact, she required complete care and required turning on a regular basis in her bed. She had developed some skin ulcers over the coccyx, and so a foam wedge had been used, and if any of you have dealt with people in wheelchairs or beds, these are the dense foam appliances that they use to lift people up and shift them this way or that. Well, they had a big wedge that they put in her bed that would keep her up on her side, keep her from going onto her back, to keep the pressure off that area. She was found dead in her bed one morning with her face in her pillow, and it was determined that she'd had a seizure. She had a seizure disorder, that was known, and she had gotten turned onto the pillow, and because of this wedge could not get back off, and so she suffocated in her pillow. So the issue of restraints, and again this would be considered a restraint under the definition because it's something that she can't manage and it's meant to control her movement, came up, and also the issue around the safety and the documentation of these restraints. And it actually came out during the investigation by the ministry that there had been an assessment of this wedge done a year before, and it was determined that it was not safe for her to use it for this very reason, that she couldn't get herself off of her face if she rolled on her face. But it wasn't documented in the record, and it was never discontinued, and the people who were using it were never told that it was a problem, and so it continued on, it continued to be used until she died. So there are recommendations here about standards of documentation for those assessments and communication of those assessments to the people who actually provide the care. And then a broader recommendation around the use of restraints, and as I said, I think we'll probably see more of these in this year's report, but the recognition that any restraint comes with risk. And I know we will do a number of cases this year where either someone has slid down and been strangled on the seatbelt of a wheelchair, or they've been caught up in bed rails. So, you know, bed rails are safety, right? But in fact, bed rails are restraints. And they do have a risk themselves. And we have a couple of cases this year where people became trapped under their bed rail and suffocated. So all restraints have a risk, and people in the industry need to recognize that and balance that risk against the benefit. Sometimes restraints are necessary in the short term, but they must be reevaluated regularly, and they must be used to a minimum. And often when we look at the big picture, the restraint poses a higher risk than actually letting people up and around. And there's other ways around it. Somebody gets out of bed at night, then we have beds now that are on the floor, almost like a mattress on the floor. We have safety pads that we can put around beds, etc. So there are options. Sometimes we do have to go to restraint, but again, the movement in the industry is away from restraint, or the use of the minimum restraints for the minimum length of time. So that was the reminder in this case. Case 6, boy, it just sounds like everybody's killing each other. Sometimes, we had a number of these. 81-year-old woman, again with aggressive behavior herself, died in a head injury sustained in an altercation with another resident. And again, this was a case where the decedent was recognized to have dementia and aggressive behavior as a result, and she was in a special care unit. So these are locked, secure units within the nursing home. But of course, they're with other people who have the same issues. And on the day in question, she entered the room of another resident, and the nurses heard an altercation going on. And when they got there, this woman was coming out of the room, she with a television remote control in her hand, and the occupant of the room standing there with a doll that she carried around. But this was a doll with a hard head. So it was a soft body, hard head, you know the type? And this particular woman had some bruising. She said that she had been struck, and she went on to develop signs of head injury. And in fact, when they did get her to the hospital, she had bleeding in her head from being struck by the head of this doll, and she went on to die as a result. So death by doll. I haven't seen a lot of those, but it does happen. Again, the same issues came up in this situation. So you've got people with this problem, you've got them together. How do you manage them? How do you keep them separate when they need to be separate? How do you minimize the aggressive behavior? How do you treat people in-house and out-of-house in order to minimize that behavior? And this particular facility actually did a bang-up job of reviewing the case and a root cause analysis of what had gone on, and they developed recommendations on their own for institution within their facility. And the committee recognized that they had done a good job at this, and in fact had come up with some good strategies and policies, and I've listed them there just for you to look at if you're interested. But basically that, you know, if somebody gets beat up and they've got an injury, they should probably go to hospital and get looked at rather than observed there. That they have a process for assessing aggressive behavior, tracking aggressive behavior, and a criteria for referring those people out to specialty consultation when they need it. And some simple things like the wandering strips, so that people can get out of their room, but people can't get in their room without having to remove this strip. So there were a number of things that were felt to be effective, and in fact, on a review at this long-term care facility, they had success with them. And so the committee's recommendation was, we don't need to reinvent the wheel, we just need to let everybody else know the good job that you did. So again, to include these recommendations in the annual report for review by other facilities. Yep.
In some of these cases, would you say that injuries that might not be fatal or barely cause any problems in a normal person, like you and I, healthy person, could be potentially fatal in these patients because of the drugs that they're on? Blood thinners is one of the things that I'm thinking of. So a punch that would mean nothing to you and I could cause internal bleeding. So are these recommendations made as well, that people are aware of this?
Yeah, and you don't even have to be on blood thinners, you just have to be old. So we know if you drop an old head on the floor, you're much more likely to disturb the blood vessels that bridge between the brain and the inside of the skull, and that's where most of these bleeding takes place. So falls in the elderly are frequently more problematic than falls in younger persons. And yes, they are often on medications either that make them fall, or that when they fall, they're more susceptible to injuries such as blood thinners. And yes, that is a thing that's been brought out in recommendations before.
Yeah, because in my experience, there's been cases where it's just a fall, it's like nothing to worry about.
Right. And in one of these cases we'll come to, there's a fairly broad discussion about falls in the report itself, and the statistics quoted were that 50% of people in long-term care facilities will fall each year, and 40% of those will have more than one fall. So falls are part of life in the elderly and in long-term care facilities. There's lots of strategies to try to reduce it. We'll never get it to zero because it is a fact of life that your balance reduces and you are more likely to fall. But there are certainly improvements that we can make in the environment that they're in to reduce that. But yeah, they're a population at risk for falls, whether it's for head injuries or whether it's for major fractures like hip fractures, both of which have a relatively high mortality rate in the elderly.
Yeah, I'm also thinking about like if there's any kind of conflict between people,
Right.
the outcome is more likely to be serious.
Yes, if I hit you on the head with a doll, you'd probably have a bump and be really mad, but that would be it. You know, somebody who's 81 and frail, that's all it took. Anything else on that case? How are we doing for time? We okay for a few more? Okay. All right. This was a 73-year-old man, again with cognitive impairment, who was non-compliant with treatment and died with kidney failure and cellulitis infection in the skin after he was sent to hospital from a nursing home. So this was one of these fellas that certainly I recognized when I read this story from family practice and psychogeriatrics and nursing home work. A fellow who had lived at home for as long as he could, who really didn't want anything from anybody. You know, don't touch me, don't move me, this is how I want to sit, this is what I want to do with my legs, with some, you know, a few swear words thrown in. And when you go to visit him, he's unbathed, he doesn't eat well, his residence is a smelly mess. And when you move him into the retirement home setting or the nursing home setting, sometimes people adjust well and they in fact love the attention and they do well with it. Others do not wish to change their ways, and this fellow was one of those. And so in spite of a lot of efforts to help this man, he was non-compliant, either by not taking his medications, or by refusing bathing, or by refusing seating assists, by refusing to keep his legs up. And so he went on to develop significant problems with skin ulcerations. And in the last week of his life, was not eating or drinking well, doing his usual no, and folks didn't realize that he was becoming progressively dehydrated and developing renal failure, which then set him up for infection coming from the skin ulcers, and he developed a cellulitis and a sepsis and ended up quite sick in the hospital and died. So the recommendations in this case had to do with the recognition that some of these people are actually sick and that they get sick in a hurry and that they can die in a hurry. So in cases like this where the staff have been dealing with this guy over a period of years and he's sort of gone along and said, I'm fine, leave me alone, the tendency is to leave him alone. And there was felt that there wasn't an appreciation that he was actually on the downhill slide for a few days and then fell off the edge. The condition of delirium is one that we have looked at before. It's a very important condition. It's not dementia, it's delirium. It's a medical emergency. Has a very high mortality rate, especially in the elderly. And there was discussion around the need to be able to recognize that and respond to that in a very timely way. Unfortunately, with this fellow, The nurses did a reasonable job, and in the end recognized that he was very sick, sent him to hospital with all the information that was necessary, and whoever saw him in hospital put him in a bed overnight and left him. No investigations and no treatment. When the doctor who took care of the long-term care home, who knew him, came on service the next day and took over his care, he recognized how sick he was and tried to get things going, but by then he was too far gone. So again, the recommendations were not just to the nursing home, but to the hospital as well, to say, hey, you've got somebody with rapid decline and delirium. That's a medical emergency. That's not a, well, we'll let somebody else see them tomorrow case. Here we go again. This was a 74-year-old man who died in a retirement home after he was assaulted by another resident, a younger man who was 34 years old. This particular topic of the variation in age of residents of long-term care facilities is also coming to the fore. Since the move away from institutionalization of people with mental health issues, there's not a lot of places for them to go. So the initial thought was, we'll close all of the mental health institutions. These people will move into the community and have appropriate supports and be fine. And as we all know, the appropriate supports were not there. Interestingly, in speaking with some of the people on my committee, what they find is happening is that when these closures all took place in the 70s and 80s and 90s, a lot of these people ended up in the care or the intermittent care of their family, particularly their parents. So young people with mental health issues ended up in the care of their parents. Now, the parents are dead, and these people are older, and there's no place for them to go except into nursing homes. So we have a rapid influx of people in their 50s with long-term mental health issues, mixing them in with people in their 80s and 90s who are frail, and you can imagine that there are some issues. There's issues in the interaction, but there's also issues for the younger person, because we didn't design nursing homes for people in their 50s, and we didn't design our recreational programs for people in their 50s and so on. So there's a problem on both sides, because we have people there who really are not getting their needs met, and we have people here who are at risk perhaps from interaction with them. And we need, that's the reality. That's not going to change, because they're not going to reopen mental health facilities. So this is where they're going to be, and we have to come to terms with that and develop a way to deal with it. In this particular case, the 74-year-old man had been in the retirement home for some time, and there was some mixed information about how long the young fellow had been there, but it wasn't like he was there for a couple of days. He'd been there months and maybe a year, and had been relatively stable. He was not particularly compliant with his antipsychotic medication, and he would at times be agitated, but he had not been known to be aggressive even when he was off his medication. And then one night, as is often the case in retirement homes, a non-licensed staff person was on duty. So it's not a nurse, it's just a babysitter, really. Some have personal support workers and others, but in this case, this wasn't a personal support worker. This was just a person. And he was in the kitchen, and I think there was another kitchen staff there with him. And they heard a commotion up on the second floor where where these fellows had their rooms. And when they entered the room, this young man, in fact, had 3 residents on the floor and was beating them seriously, such that the individuals there were frightened for themselves, and so they retreated and called for help. And by the time the police arrived, 2 of them were seriously injured and one was dead. So the review of this case, in fact, didn't generate any recommendations, because the committee felt it was not predictable. In other words, this came completely out of the blue for this guy. He had been in the facility, they had been interacting, there had been no issues in the past. There was nothing done or not done that precipitated this. It was part of the disease, unfortunately. Whether he'd have been in the home that night or on the street or wherever, it probably was going to happen. So there weren't recommendations, because the committee said, what do you do in those situations, except to say, well, never put people together who have mental illness, but that's just not a practical recommendation. You're not going to want to go to a nursing home, are you? Unfortunately, that's what a lot of our committee members say.
You were saying nursing home, and yet at the top it said retirement home.
Yes,
Is
that
this a
was,
retirement
that
home?
was a retirement home, so that's right, it was an unlicensed facility. And that's, you know, that's where a lot of folks with psychiatric history end up,
In retirement.
in private retirement homes. Often because the licensed long-term care facilities won't take them.
Yeah, they won't.
Yeah, so, but the private facilities want to fill their homes, and so I know, you know, from my own practice, that the replacement for the mental health hospital, for the institution, was a number of private retirement or boarding house facilities that took these people in and gave them housing and food, but that's about, you know, that's about all that they give. But they have a place to sleep that's warm and dry, and they have food 3 times a day. But they don't have treatment for their illness within the facility. They have to seek that somewhere else. And they don't have staff who are specifically trained to deal with those issues.
So it's more like the old boarding house.
Exactly like the old boarding house, yeah, and that's what this was. This case, sorry folks, I'm going to catch up here with myself, remind myself. So this was an 84-year-old woman who died again of urosepsis. So this is an overwhelming infection that started as a bladder infection after she was transferred to hospital from a long-term care facility. The issue in this case was the delay in the diagnosis and the treatment. So this woman was, it was documented that there was concern that she had a urinary tract infection, but nothing was done. So a urine was not sent and treatment was not started. So often in the cases of urinary infection, we might not even choose to do a urine culture. We'll treat, as we say, empirically. We'll pick the drug that we know is likely to do it, and we'll just treat them for a few days, and that's an acceptable way to go. But in this case, neither was done. So it wasn't investigated, it wasn't treated. And about a week later, she declined very rapidly, and it wasn't until then that the physician was notified. But the physician was notified by the nursing staff by leaving a message with his secretary. So although she had evidence of a low blood pressure and she was in shock, basically, the decision was made to phone the doctor's office and leave a message. So of course, the doctor's busy, doesn't have an appreciation of what it is. So a few hours later, when the doctor takes the message and calls them back, he quickly recognizes that they're in trouble. And he attends her right away and sends her to hospital, but she's quite sick and she dies. So again, recommendations around care and management, around the training of nursing staff to be able to recognize that sometimes simple problems can become serious problems if they're not managed appropriately at the outset. And urinary infections is a common one. And either you investigate them or you treat them, but you should do one or the other. And then the issue of communications, that this facility needed to have a policy in place for communicating with the physician when there was an acute or sudden change in the status of the individual. And leaving a message wasn't felt to be acceptable. It needed to be direct communication that this person's really sick, we need some help. This was a case of an 85-year-old woman who had a fall in a long-term care facility within 2 weeks of being admitted, and she suffered a head injury and she died as a result. Now the reason this case came to the committee was that the family complained that their mother had not been adequately cared for and protected in the long-term care facility. And they felt, their expectation was that she would not have falls in the long-term care facility. So she had been managed at home by the family, but was having increasing problems with falls, and they recognized the risk. And so they met with they had applied for placement and met with the staff when she was assigned a facility. And in fact, the staff had documented very well the discussions around fall risk. And they made it quite clear that coming to the nursing home does not stop falls. And that yes, we could tie her in a chair and tie her in her bed, but that has problems of its own. And generally, when you tie people down and you let them up, they fall. So you create a problem, plus all the problems of being immobile. And so they made it clear to the family at the outset that they would not be restraining this woman, that they would take measures to try to reduce her fall risk through looking at her medications, her mobility, safety in her room, a walking aid, and so on. And they did that. But she refused the walker. She didn't need a walker. And she did her own thing, and she fell. And the family felt that they had that the facility had not done their job. The only thing the facility hadn't done was to document the separate elements of the fall risk plan into one big fall risk plan, and that was the only criticism. But in fact, they'd done all that they were supposed to do, and the committee recognized that. And in the end, they said, "Look, people get old and people fall, and nursing homes don't prevent falls. We can do things to make it better, but they are still going to fall, and if they fall, they will suffer injuries." And that's the reality. So people need to be informed of that. They need to have informed consent and understand that is the reality. And the last one, again, a 73-year-old man had a fall in hospital and died of a head injury. By the way, that case number 10, if you're interested, does have a very good discussion on the issue of falls and fall risk and so on. This case was a gentleman who, again, was in a retirement home, not a licensed long-term care facility. He had come from home because he wasn't able to manage any longer. He had a history of alcoholism, but had not been drinking heavily. On the day in question, he had called a taxi to deliver him some alcohol, and he had had a drink, and he had a fall. The staff assisted him at the time. He did not seem to have suffered any injury. He did smell of alcohol. The family was notified, and they said, "Please remove the alcohol from his room," which was done. And you've got to understand that in a retirement home especially, this is their residence. They're independent people, so I can't go into your house and take your alcohol. If you want to have alcohol, that's up to you. But in this case, they actually did remove it with the family's consent, and they called an ambulance because he had fallen, so they did the right things. The ambulance came and assessed him, and he said, "I'm fine, I don't want to go with you, leave me alone," which they did. Then he went on to develop vomiting and signs of trouble in his head, and he went to hospital. And he had bleeding in his head, but it was actually determined that the bleeding was a primary bleed, not from the fall. So he had a stroke, a bleeding stroke, that made him fall, but not a fall that made him bleed. So the only thing that came out of this was the recognition that even though people are in a retirement home and they're not required by law to have certain standards in their recording of information. In fact, there was licensed nursing staff who worked in this facility, and they felt that their documentation of the work that they did not meet the standard of the profession. And so it was recommended that even though it's a retirement home and there isn't somebody coming to inspect you, when you make nursing notes, they should be timely, because these notes were put in a week after the fact, so that always makes everybody a little bit upset. And they should be fulsome. And the second thing they recommended was that when paramedics do an assessment and decide to leave somebody, they should have they have a checklist that they go through, and they document the conversation that they've had to make sure that they've covered off all the issues. But one of the things that's not on there is mobility. And it was suggested that in his case, if they'd have asked him to get up and walk across the room, they probably would have realized that he was significantly impaired, not from alcohol, but from his head injury. And so it was recommended through the Ministry of Health that should be added to the paramedic record, which is something that they're looking at adding. So again, a practical little tidbit for those to, again, try to avoid that situation. Would it have made any difference? Probably not. He had a very significant bleed, and probably if he'd have gone to hospital at that time and they scanned his head, they would have said, there's nothing we can do here, you're going to die. So And those are the cases. So current issues that are before the committee and things certainly that we're keen to look at. We've talked about licensed versus unlicensed facilities. And there is now in the works the Retirement Homes Act in the province of Ontario, which is going to be, I'm not going to say imposed upon, but which will involve what are currently private unlicensed retirement homes. And will set some standards of care and will allow for inspection of the homes to make sure that they meet those standards. Most of the standards are around safety, the development of care plans, communication, a resident's constitution so that their rights are known to them and so on. But it is a step in the right direction. And we're keenly interested to see how that rolls out and what effect it has. And the Office of the Chief Coroner has been in communication with the people who are developing this program to assist them. The issue of restraints, we will certainly be continuing to look at. The issue of wound care, and again, as more people, older people, less mobile people are in homes, wound care becomes more and more of an issue. Medications, especially polypharmacy and interaction between medications. And the big one in the last year has been the use of antipsychotics in dementia. So it's a very popular thing to use schizophrenia drugs for behavioral issues in dementia. And there is some evidence, although it's not strong evidence, that there might be some benefit to some people. But there's also evidence that it kills people. So we have to weigh that and we have to make those determinations, and certainly the committee's interested in being involved in these cases to try to make recommendations for further research in that area. And in fact, when I attended the Ontario Long-Term Care Physicians meeting this year, that topic took up pretty well the whole convention, so it's certainly a big one.
I know a while back there were some discussions about a central database where actually data would be gathered on particular drugs, off-label drugs, antipsychotic drugs, that can be used, and the side effects or potential usefulness of these drugs. In the elderly, this goes back now a few years. Has anything been done on that front, or is
so you're talking like an educational database where you could exactly. Log in and say, what if I mix this drug with this?
It's a voluntary educational database, not an imposed one.
So there is a service available through the Ontario Pharmacists Association where physicians and facilities can call in and get advice and can log on and get some advice. So it is there, but it's not very widely used. The other thing is that most licensed long-term care facilities, in fact I think all of them, have a service, have access to a pharmacist because all of their medications are prepared in a pharmacy and supplied to them. But again, that interaction is not...
Yeah, I guess what I was talking about is data gathering somewhat in line with clinical trials, except not documented clinical trials, but very defined endpoints, very defined points that you're going to look at, interactions and so on.
Yeah, the database on interactions is there. I don't have the reference with me, but there is actually a site that you can go to, and it is a compilation of the data that's been collected through research, which has a list of the drugs and their interactions that as it applies specifically to the elderly. And I think it has the top 80 drugs that you should avoid and that sort of thing. So that is there. Again, it's there, but we got to get people to use
I guess
it, to
I
use
was
the tool.
thinking more in terms of antipsychotic and the use of chemical restraints as more and more people with dementia entering nursing homes, and there's going to be this big issue.
And it's recognized that it's not well researched, but it is in the last couple of years getting the attention it probably deserves, and that research is coming.
There was an online question here, and they ask, are there any incidents of death by suicide in long-term care facilities? And if so, what were the recommendations?
We didn't do any suicides in the last year, but yes, there are. If I can go back to my previous slide, you'll see that suicides in that period, 4 to 11 a year. But none of them came to the committee in the last year, so I can't speak on any current recommendations. But suicide is a reality in the elderly, yes. Is it preventable? Probably the same, a lot of the same strategies that apply to suicide prevention in general are applicable. But I can't comment on specifically anything that the committee's looked at recently.
It's only a comment, and I think what it is a pharmacist that I know who worked in a number of long-term care homes was really saying that some of the difficulties which she experiences is the way in which drugs are given to patients. That they sometimes are, a pill is matched when it shouldn't be, and
right.
a variety of giving it with food and it shouldn't be because it's easier to give it.
Right.
And so is anything coming out about?
Yeah, I haven't seen anything in particular about that. It is an issue because obviously, for example, you have a sustained release product. If you crush it, that's an issue. And you'd hope that that would be recognized, but I know that it is not always. And certainly for some elderly, swallowing is a real issue. But we haven't seen any deaths as a result of that at the committee. Any other questions?
And just out of curiosity, it seems as though like a lot of these deaths are because of competency. So I'm just wondering, like, how often are these people assessed, especially in like retirement homes where obviously they are put in the retirement facility because they are competent, but in a nursing facility, if they aren't, and then they're not taking their medications, what would be done for something like that?
So it depends. So if they have a substitute decision maker, and the clinicians feel that the drug is life-saving, that without the drug they won't be able to live, then the decision has to be made by the substitute decision maker as to whether or not they're going to find a way to administer that. But I would say, for the most part, if drugs are refused, drugs are refused. It's pretty difficult to give people what they don't want unless you're going to be injecting them. And I think for most people, when you're dealing with the elderly population, if they have dementia, their life expectancy is short, and perhaps you might feel their life quality is not great. So why would you inflict that? Why would you hold them down and make them take something or inject them with something? So I would say for the most part, if it's a situation where they're refusing, that would not be pursued as an option. If it's a behavioral issue where they are aggressive and they need sedation, that's a different story, because that then becomes an issue of safety for them and for the other people in the unit. And that's the situations where drugs would be administered without consent. But again, not long-term. It would be a short-term issue. And usually in those settings, if you can give them short-term, you can get them to a position where they'll actually take them voluntarily for the most part. So. But that's considered restraint. So, again, you've got to turn your mind to the risk versus the benefits. Any other comments? Thank you very much.